area. Alright, so pain in abdomen, pain in ectopic pregnancy site is lower abdomen or pelvic area. Unilateral pain, nature can be mild, severe, blunt, sharp, constant or intermittent. In ruptured ectopic, the pain is due to hemoperitoneum. In unruptured ectopic, it is due to stretching of the tubes, and pain arises at nerve roots of T11, T12, L1, T11, T12, L1. In case of ruptured ectopic, there is abrupt onset of severe pain. In case of ruptured ectopic, there is abrupt onset of severe pain. Pain of middle or upper abdomen is seen in cases of intraperitoneal blood which reaches the upper abdomen. In abdominal ectopic pregnancy, pain may be present. If intraperitoneal blood reaches the diaphragm, it irritates the diaphragm, which will cause shoulder tip pain, and pooling of blood in cul-de-sac, which is pouch of Douglas, pressure on rectum, which is the urge to defecate. History indicating to ruptured ectopic is shoulder tip pain, syncope, attack, postural hypotension. Ectopic pregnancy examination. First of all, ruptured ectopicus shock index will be more than 0.85. Tachycardia, hypotension, abdominal distension, rebound tenderness, guarding rigidity. Most significant finding would be the presence of adnexal mass, and you will also have cervical motion tenderness. Most significant finding is the presence of adnexal mass and cervical motion tenderness. Unruptured ectopic, it is not significant, and you also have per abdomen examination findings, which is also not again not significant. Okay. So in ruptured, tachycardia, hypotension, abdominal distension, rebound tenderness, guarding rigidity. Most significant finding is the presence of adnexal mass. Most significant is the adnexal mass. Presence of adnexal mass is the most significant finding, and cervical motion tenderness. Pain even on touching the cervix during PD examination. This happens due to salpingitis, which further causes peritonitis. Pain even on touching the cervix. Pain even on touching the cervix during per-vaginal examination. Pain even on touching the cervix during per-vaginal examination. This occurs due to salpingitis, which further causes peritonitis. It occurs in both pelvic inflammatory disease and ectopic pregnancy. Uterus enlarges due to endocrine changes of pregnancy and softens, but size is smaller than the period of gestation. Uterus will enlarge due to endocrine changes of pregnancy, and it will soften, but the size is smaller than the period of gestation. Cervical motion tenderness is found in both ectopic pregnancy and in pelvic inflammatory disease. 6 to 8 weeks amenorrhea, spotting and pain in the abdomen with unstable vitals. Next you have to do UPT. UPT will be positive in both intrauterine pregnancy and ectopic pregnancy. Resuscitate the patient. Next step, UPT positive, resuscitate the patient. Do per-abdominal examination. If localizing signs are negative, you can do localizing signs like guarding and rigidity are absent, then you have to do EFAST. You have to do FAST, and if intraperitoneal bleeding is present, we will do laparotomy. If localizing signs are present, then also we will do laparotomy. Best management for ruptured ectopic is surgery. Best management for ruptured ectopic is surgery. No role of medical management or expectant management. No role of medical management or expectant management. Is route of surgery. Vitals are unstable, which means vitals unstable is laparotomy. Vitals stable means laparoscopy. Surgery of choice would be unilateral salpingectomy, which is irrespective of priming gravida or multigravida. No role of any other surgery like salpingostomy. So best management for ruptured ectopic would be surgery. Best management of ruptured ectopic would be surgery. There is no role of medical management or expectant management. There is no role of medical management or expectant management. And route of surgery would be vitals are unstable. Vitals unstable. If the route of surgery in unstable vitals is laparotomy. If the vitals are stable, we will do laparoscopy. Unstable laparotomy, stable laparoscopy. Surgery of choice would be unilateral salpingectomy, irrespective of primi or multigravida. Unilateral salpingectomy. No role of any other surgery like salpingostomy. If it is a primi with positive UPT, amenorrhea 5 weeks, BP, guarding and rigidity present, complaints of pain in the abdomen, the next step would be laparoscopy and salpingectomy. Laparoscopy and salpingectomy. Cultocentesis is through the posterior fornix of vagina, blood is aspirated. Cultocentesis through the for ruptured ectopic, it is surgery only. Okay. Now cultocentesis through the posterior fornix of vagina, blood is aspirated from the pouch of Douglas. Hemoperitoneum can be detected. For cultocentesis, you take blood and leave it in the syringe for 5 minutes. If the blood clots, it means the needle has entered into blood vessels. If the blood does not clot, it means it is hemoperitoneum and it is a ruptured ectopic. Female with 6 to 8 weeks of amenorrhea, pain in the abdomen and spotting, vitals are stable. The next step would be UPT. 99% ectopics will be positive. Investigation of choice would be transvaginal sonography. If the patient is stable, we will do a TVS. In the TVS, findings diagnostic of intrauterine pregnancy, findings diagnostic of ectopic pregnancy, or findings suggestive of ectopic pregnancy. Signs on TVS seen in intrauterine pregnancy are pregnancy. If it is an intrauterine pregnancy, you will have an intradecidual sign, a double Bleb sign, and a double decidual sac sign. You will have a double Bleb sign, double decidual sac sign, and intradecidual sign. Intradecidual, double Bleb sign, and double decidual sac sign. Okay, intradecidual double Bleb sign and double decidual sac sign. For definitive diagnosis of ectopic pregnancies, extrauterine gestational sac with yolk sac or embryo with or without cardiac activity. Extrauterine gestational sac with yolk sac or embryo with or without cardiac activity. Presence of gestational sac alone is not diagnostic of ectopic pregnancy. It is suggestive of presence of gestational sac alone with or without yolk sac or embryo with or without. So gestational sac with yolk sac or embryo with or without cardiac activity. The extrauterine gestational sac with yolk sac or embryo with or without cardiac activity. Presence of gestational sac alone is not diagnostic of ectopic pregnancy. It is suggestive of ectopic pregnancy. Presence of gestational sac alone is not diagnostic of ectopic pregnancy. It is suggestive of ectopic pregnancy. Signs on transvaginal sonography which is suggestive of ectopic pregnancy is empty uterus. So suggestive means presence of gestational sac alone is not diagnostic, it is only suggestive. Similarly, an empty uterus, a complete adnexal mass with increased vascularity or ring of fire. Empty uterus, complex adnexal mass, which is most common, seen in 89% cases. Increased vascularity of the mass is ring of fire appearance. Gestational sac in the tube without yolk sac or without embryo. So complete uterus, that is empty uterus, complex adnexal mass is the most common thing, which is seen in 89% of cases. Complex adnexal mass is most common, it is seen in 89% of cases. You have the complex adnexal mass and increased vascularity of the mass, which is a ring of fire appearance. Gestational sac in the tube without yolk sac, with or without embryo. Increased vascularity of mass or ring of fire appearance. Gestational sac in the tube without yolk sac or without embryo. Next step of suggestive of ectopic pregnancy, serial HCG estimation. So serial HCG estimation. Gestational sac with yolk sac or embryo without cardiac activity. Without yolk sac, gestational sac in the tube without yolk sac or without embryo, increased vascularity of the mass, which means it will have a ring of fire appearance. Complex adnexal mass is most common, seen in 89% of cases, and you also have an empty uterus. HCG you will have a discriminatory score or a critical titer, the value of HCG above which an intrauterine pregnancy on ultrasound. In 100% cases, gestational sac will be visible. So discriminatory score or critical score. Discriminatory score or critical score. Or critical score of HCG. Discriminatory score or critical score of HCG is if a TVS, the value will be TVS 2000 international units, and for trans-abdominal sonography it will be 6500 international units. 6000 okay, for ectopic pregnancy, right? For intrauterine pregnancy in which gestational sac will be visible. So transvaginal sonography will be 2000 and trans-abdominal sonography is 6500. If patient's HCG levels are more than 2000 and intrauterine gestational sac is not visible, it is a case of ectopic pregnancy. If patient's HCG levels are more than 2000 and intrauterine gestational sac is not visible, it is a case of ectopic pregnancy. Maximum level of HCG at which gestational sac should be visible on TVS in intrauterine pregnancy is 2000. Minimum level of HCG at which gestational sac can be visible on TVS in intrauterine pregnancy is 1000 or 2 is 1000. So minimum level of HCG at which gestational sac can be visible on TVS is 1000. In early intrauterine pregnancy, the level of HCG roughly doubles in 48 hours, which means it will increase by 35 to 65%. But in ectopic pregnancy, level of HCG increase in 48 hours but increase less than 35%. So in early intrauterine pregnancy, the level of HCG will roughly double in 48 hours. Level of HCG roughly doubles in 48 hours, which means it will increase by 35 to 65%. But in case of ectopic pregnancy, the level of HCG will increase in 48 hours, but the increase is less than 35%. Non-viable intrauterine pregnancy. In case of aborting or dying pregnancy, the level of HCG will decrease after 48 hours. Non-viable or intrauterine. Non-viable or intrauterine pregnancy. In case of aborting or dying pregnancy, the level of HCG will decrease after 48 hours. Female with 6 weeks of amenorrhea complains of pain with spotting, UPT positive on TVS, empty uterus and complex adnexal mass. You have a female, she's coming with 6 weeks of amenorrhea, complains of pain, spotting, UPT positive, TVS, empty uterus, complex adnexal mass. Findings are suggestive of ectopic pregnancy. First, you have to do a serial HCG measurements. Decrease after 48 hours. So serial HCG. If HCG is more than 2000, which is the critical titer, still getting empty uterus, it is an ectopic pregnancy and you have to manage the ectopic. If HCG is less than 2000, repeat HCG in 48 hours. If level of HCG increase and nearly double, it is an intrauterine pregnancy. If the level will increase and it is nearly double, it is intrauterine pregnancy. If the levels decrease, it is an abortion. Okay, and if levels of HCG increase but it is less than 35%, which means it is a slow rise in HCG, ectopic pregnancy. Gold standard to diagnose ectopic pregnancy. If the levels of HCG increase and it is less, it is ectopic pregnancy. You have to manage the ectopic. Serum progesterone levels more than 25 nanogram per deciliter. Most common sites: ampulla, isthmus. Ampulla, isthmus, ampulla, isthmus. Fimbriae interstitium is the least common site. Ampulla, isthmus, infundibulum, interstitium. Interstitium is the least common site. Increase, maximally increase prior tubal surgery. The point leads to endometrial sloughing in ectopic gestation. Fall in which of the hormones will lead to endometrial sloughing? Progesterone and HCG. Progesterone. Which type of tubal pregnancy ruptures at a later stage? Interstitial. Is not seen with ruptured ectopic pregnancy. And then 8.5. Serum progesterone levels more than 25 nanogram per ml will indicate viable intrauterine pregnancy. Less than 5 nanogram per ml will indicate non-viable intrauterine pregnancy or ectopic pregnancy. More than 25 nanogram per ml. Serum progesterone levels more than 25 nanogram per ml will indicate viable intrauterine pregnancy. Less than 5 nanogram per ml will indicate non-viable intrauterine pregnancy or ectopic pregnancy. Progesterone levels more than 25 nanogram per ml will indicate viable intrauterine pregnancy. Less than 25 nanogram per ml will indicate non-viable intrauterine pregnancy. Will indicate non-viable intrauterine pregnancy or ectopic pregnancy. On uterine aspiration in ectopic pregnancy, only decidua, no chorionic villi will be present. More than 25 is a viable pregnancy. Less than 5 nanogram per ml indicates non-viable or intrauterine pregnancy. In non-viable intrauterine pregnancy, chorionic villi are present in the decidua. On uterine aspiration in non-viable intrauterine pregnancy, chorionic. If it is a non-viable intrauterine pregnancy, chorionic villi will be present in the decidua. In ectopic pregnancy, only uterine aspiration only decidua will be present, no chorionic villi. മറ്റേതിൽ chorionic villi will be present. Tests which are not done: hysterosalpingography, hysteroscopy, colpotomy. Hysterosalpingography, hysteroscopy and colpotomy are not done. Now, management of unruptured ectopic pregnancy, we can do expected management, which is the least preferred. Wait for ectopic pregnancy to resolve spontaneously. Medical management is best preferred for unruptured ectopic pregnancy, where the best or preferred method of management. Prerequisite for medical management should be fulfilled. Prerequisite for medical management should be fulfilled. So, expected management, medical management, surgical management, these preferred. Wait for ectopic pregnancy to resolve spontaneously. Best or preferred management is prerequisite for medical management should be fulfilled. Done if the prerequisite of medical management are not fulfilled. Ruptured ectopic. For ruptured ectopic, and if the prerequisites for medical management are not fulfilled, we will do surgical management. Medical management: vitals of the mother should be stable, family is not complete, HCG less than 5000, size of gestational sac less than 4 cm, cardiac activity is absent, which is not an absolute requirement. In cases where cardiac activity is present, preferred management is surgical, but medical management can be done although the chances of failure increases. In cases where cardiac activity is present, medical management, so it is not an absolute requirement. Cardiac activity absent is not an absolute requirement. In cases where cardiac activity is present, preferred management is surgical, but medical management can be done although the chances of failure increases. In cases where cardiac activity is present, medical management should only be done for the size of the sac less than 3.5 centimeters. Medical management is done only if the patient is stable, that is unruptured ectopic, not complete. Family is not complete, less than 5,000 international units. Size of the gestational sac is less than 4 centimeters. And cardiac activity is absent. This is not an absolute requirement. In cases where the cardiac activity is present, preferred management is surgical, but medical management can be done, although the chances of failure increases. Well, cardiac activity is present, preferred management is surgical, but medical management can also be done, although the chances of failure increases. In cases where cardiac activity is present, medical management should only be done for the size of sac less than 3.5 centimeters. If cardiac activity is present, only if the sac is less than 3.5 centimeters, you can do medical management. Otherwise, HCG should be less than 5,000 and size of the gestational sac should be less than 4 centimeters. Now, in case conditions for expectant management are: patient should be hemodynamically stable. Expectant management: hemodynamically stable, no visible sac, HCG less than 200 with a falling trend. Expectant management is patient is hemodynamically stable with no visible sac, HCG less than 200 with a falling trend. Medical management for ectopic pregnancy is: drug of choice is methotrexate. We will give dose 50 milligram per meter squared intramuscularly. 50 milligram per meter squared. Methotrexate 50 milligram per meter squared and intramuscularly. Other drugs are KCl, actinomycin, hyperosmolar glucose and PGF2 alpha. KCl, actinomycin, hyperosmolar glucose and PGF2 alpha. KCl, actinomycin, hyperosmolar glucose and PGF2 alpha. KCl, actinomycin, hyperosmolar glucose and KCl, PGF2 alpha, hyperosmolar glucose and actinomycin. Protocol is a single dose of methotrexate, injection methotrexate the entire dose. Measure baseline HCG levels. Again, we have to recheck on day 4, day 7. So, single dose on day 1, single dose, injection methotrexate, full dose, measure baseline HCG levels, recheck on day 4 and day 7. And successful medical management will show decrease in HCG levels between D4 and D7. Decrease should be more than 15%. A successful medical management will show decrease in HCG levels between day 4 and D7 of more than 15%. If decrease on day 7 is less than 15% from D4, we have to repeat methotrexate injection. A decrease in day 7 is more than 15 is less than 15%, we have to repeat methotrexate injection. Maximum 3 times methotrexate can be given. Failed medical management is an indication for surgical management. Multi-dose protocol is, here we are giving 50 milligram per meter squared. There we, for multi-dose 1 milligram per kg plus 0.1 milligram per kg. Alternate doses daily. Alternate doses on days 0, 1, 3, 5, 7. If a female with ectopic pregnancy with gestational sac 2.5 centimeters and 3000, we can give methotrexate. Day 1 injection is given. Day 3 it is becoming 3200. Next step, between day 1 and day 4 levels, between day 1 and day 4, HCG levels can increase, could rise. It is not an indication of failed medical management. Cause shrinking sac releases HCG, hence HCG will rise. Now check HCG levels on day 7. HCG should not rise between day 4 and day 7. Same patient, day 4 she has 3400 and day 7 she has 4000. There is a rising trend. So case of failed management, next step becomes surgical management. The values increase between day 4 and day 7. It is a case of failed medical management. So we have to do surgical management. Case 3 is a same patient we are taking day 4 3400 and day 7 3200. It has decreased, but decrease in the value is less than 15%. So we have to repeat injection methotrexate. And day 4 3400 and then coming 2000, decrease is greater than 15%. Case of successful medical management, repeat HCG values weekly till they become undetectable. Precautions during therapy: avoid intercourse and new conception until HCG is undetectable. Avoid pelvic examination during surveillance of methotrexate therapy due to theoretical risk of tubal rupture. Avoid sun exposure to limit risk of methotrexate dermatitis. Avoid vitamins containing folic acid. Avoid NSAIDs, as methotrexate and NSAID interaction will decrease renal excretion of methotrexate, hence increases chances of toxicity. Avoid intercourse and new conception until HCG is undetectable, and then you have to avoid pelvic examination during surveillance of methotrexate therapy due to theoretical risk of tubal rupture. Avoid sun exposure because there will be risk of methotrexate dermatitis. Avoid vitamins containing folic acid. Avoid sun exposure. Avoid NSAIDs because there can be an interaction between methotrexate and NSAIDs which will decrease the renal excretion of methotrexate. Pain after treatment: if the female is on methotrexate for ectopic pregnancy and she complains of mild to moderate pain, treatment is acetaminophen. The pain is due to tubal abortion or tubal distension due to hematoma. This pain is due to tubal abortion or tubal distension due to hematoma. Female on methotrexate complains of severe pain, possibly a case of tubal rupture. Management is TDS plus vitals monitoring. Plus TDS is done. Okay. It could be hemoperitoneum. Surgical management of unruptured ectopic will be root. Surgical management of unruptured ectopic, laparoscopy. Surgery of choice: that if the family is complete, it is salpingectomy. If the family is not complete, it is salpingostomy or linear salpingostomy. So for surgical management of unruptured ectopic, the route that we prefer is laparoscopy. If the family is complete, we will do salpingectomy. Otherwise, we will do salpingostomy. Salpingostomy is to make an incision on the anti-mesenteric part directly over the distended tubal part. Remove the ectopic by hydrodissection. Leave the tube and incision site. No sutures are required. It heals by secondary injection. If family is not complete, size of the sac is more than 5 centimeters and it is an unruptured ectopic, we have to do salpingectomy. Not complete, but the size of the sac is more than 5 centimeters and it is an unruptured ectopic, we will do salpingectomy. Should salpingo-oophorectomy be done? No, except in cases of ovarian ectopic. If it is ovaries, we can do Spiegelberg criteria. Abdominal is Studiform criteria, and cervical ectopic is Rubin and Palman and Rubin or Rubin criteria. When salpingectomy is done laparoscopically, you have to stay near the infundibulo-ovarian ligament and cut this ligament. Stay away from infundibulopelvic ligament as it contains ovarian vessels and nerves. Stay near the infundibulo-ovarian ligament. And cut this ligament. You have to stay away from the infundibulopelvic ligament as it contains ovarian vessels and nerves. Stay away from the infundibulopelvic ligament. As it contains ovarian vessels and nerves. If damaged, it could lead to menopause-like symptoms and amenorrhea at a young age. While cauterizing the tube, stay away from the uterus as it can lead to a uteroperitoneal fistula. Gestational trophoblastic disease. When the trophoblast of placenta undergoes abnormal proliferation, it results in gestational trophoblastic disease, which is a benign condition with malignant potential. So when the trophoblast of placenta undergoes abnormal proliferation, it results in trophoblastic disease. When the trophoblast of placenta undergoes abnormal proliferation, it will result in gestational trophoblastic disease. When the trophoblast of placenta undergoes abnormal proliferation, it will result in gestational trophoblastic disease, which is a benign condition which has malignant potential. Trophoblast of placenta undergoes a modified WHO classification of gestational trophoblastic disease is hydatidiform. Molar pregnancies like hydatidiform mole, benign, complete and partial. Invasive is malignant. Molar pregnancies are hydatidiform mole, which is complete or partial. Molar pregnancy and trophoblastic tumors. So gestational trophoblastic disease can be classified into in the basis of as molar pregnancies, which is complete or partial mole, and invasive mole. Hydatidiform mole and invasive mole. And then you also have trophoblastic tumors. Trophoblastic tumors are choriocarcinoma, placental site trophoblastic tumor, and epithelioid trophoblastic tumor. Epithelioid trophoblastic tumor. Okay, so placental site choriocarcinoma, placental site trophoblastic tumor, and epithelioid trophoblastic tumor. Molar pregnancy will be complete mole, invasive mole. Gestational trophoblastic neoplasia. Neoplasia is choriocarcinoma. Gestational trophoblastic neoplasia is choriocarcinoma, and then choriocarcinoma, invasive mode, placental site trophoblastic tumor, epithelioid trophoblastic tumor. So gestational trophoblastic will be everything other than molar hydatidiform mode. Each gestational trophoblastic neoplasia has a different histological characteristic. They are mostly diagnosed based on clinical examination, HCG levels, and treated with chemotherapy as gestational trophoblastic neoplasia. Risk factors. Single most risk factor is previous history of molar pregnancy. Single most risk factor is the previous history of molar pregnancy. Previous history of molar pregnancy is the single most important risk factor. Age of the patient. Chances are high at both extremes of age, adolescent age and more than 40 years. Over from these age groups is susceptible to abnormal fertilization, most common in Southeast Asian populations. Age of the patient is chances are high at both extremes of age, adolescent age and more than 40 years of age. Chances are high at both extremes of age, adolescent age and more than 40 years of age. Over from these age groups are susceptible to abnormal fertilization, most common in Southeast Asian countries. Chances are high at both extremes of age, adolescent age and more than 40 years of age. Most common in Southeast Asian countries. Okay, so age of the patient, most important risk factors, previous history of molar pregnancy, and age at both ages, adolescent and extremes, more than 40. Molar pregnancy or hydatidiform mole is abnormal proliferation of trophoblast. Abnormal proliferation of trophoblast where size of the uterus is more than period of gestation. In molar pregnancy, along with trophoblastic proliferation, there is also hydropic degeneration. Types. Complete mole has no fetal tissue. Partial mole has fetal tissue may be present. Partial mole may have some fetal tissue. Pregnancy has to end. Most common presentation will be vaginal bleeding. Patient has early onset pregnancy induced hypertension. Most common presentation will be vaginal bleeding. Patient has early onset pregnancy induced hypertension. Investigation is USG. USG is a snowstorm appearance due to undue proliferation of trophoblast. Increased levels of beta HCG. HCG more than period of gestation leads to hyperemesis gravidarum, which has an alpha subunit of HCG which is similar to alpha subunit of TSH, and hyperthyroidism. It will lead to the formation of bilateral theca lutein cyst in the ovary, which is HCG has functional similarity with LH and FSH. So USG means it has a snowstorm appearance. On USG there will be a snowstorm appearance. Snowstorm appearance on USG due to the undue proliferation of trophoblast, which will cause increased levels of beta HCG, and HCG will be more than period of gestation, which will lead to hyperemesis gravidarum. Alpha subunit of HCG is similar to the alpha subunit of TSH, so hyperthyroidism. Alpha subunit of HCG is similar to the alpha subunit of TSH, so hyperthyroidism. It will lead to the formation of bilateral theca lutein cyst in the ovary. It will lead to the formation of bilateral theca lutein cyst in the ovary. And HCG has functional similarity with LH and FSH. So it will lead to hyperthyroidism, formation of bilateral theca lutein cyst in the ovary, and hyperemesis gravidarum also. Placenta has two types of trophoblast. Syncytial trophoblast is highly differentiated, which secretes HCG. Syncytial trophoblast highly differentiated, secretes HCG. Cytotrophoblast or primitive trophoblast, which does not secrete any hormone. Intermediate trophoblast, which invades the decidua, myometrium and blood vessels, secrete HCG not to the same level as syncytial trophoblast. Epithelial trophoblastic tumor and ASTA. Placental site trophoblastic tumor and epithelial trophoblastic tumor will arise from intermediate trophoblast. Okay, so intermediate trophoblast gives rise to placental site trophoblastic tumor. Endothelial intermediate trophoblast gives rise to placental site trophoblastic tumor, and epithelial trophoblastic tumor, epithelial trophoblastic tumor. HCG is not used as tumor marker in these conditions. HCG is not a tumor marker in these conditions. Now pathogenesis, partial mole will be triploid, 69XXY or XXX and rarely XYY. So partial mole will be triploid, whereas most common is 69XXY, most common 69XXY. Extra chromatin is paternal, it is dispermic. So partial mole is paternal, partial mole will be triploid with 69XXY being most common. Extra chromatin will be paternal and it is dispermic. Complete mole or vesicular mole will have maternal chromosomal inactivation. Complete mole is completely paternal, which means it has maternal chromosomal inactivation. Maternal chromosomal inactivation, empty egg. So maternal chromosomal inactivation with paternal chromosomal duplication. So it will be diploid. Complete mole is diploid, 46XX. Entire chromosomal material will be paternal in origin, which is androgenesis. 80% of the cases it will be monospermic and 20% of the cases it will be dispermic. So partial mole will be dispermic. Partial mole will be dispermic, whereas complete mole will be 80% will be monospermic and 20% will be dispermic. Twin pregnancy, one normal fetus, another molar pregnancy. If it is one normal fetus and another molar pregnancy, क्या होता है? If it is one normal fetus, one molar pregnancy, there will be complications to the surviving twin which will cause abortion, preeclampsia, hemorrhage, thyrotoxicosis. Abortion, preeclampsia, hemorrhage and thyrotoxicosis. Abortion, preeclampsia, hemorrhage, thyrotoxicosis. Complete or partial mole, you have a complete mole and a partial mole. So complete mole will be 46XX. It will be diploid, this will be triploid. Maternal gene will be absent in a complete mole, present in a partial mole. P57 KIP2, KIP2 immunostaining, which is paternal gene which is maternally expressed, which is negative. P57 KIP2 will be negative in a complete mole, positive in a partial mole. Most common symptom in a complete mole will be first trimester bleeding. Some females may complain of grape-like vesicles coming out. So most common symptom for a complete mole is first trimester bleeding. Some females may complain of grape-like vesicles coming out. On USG, the investigation of choice is a complex echogenic intrauterine content with cystic anechoic spaces known as snowstorm appearance. Complex echogenic intrauterine content with cystic anechoic spaces. Complex echoic intrauterine content with cystic anechoic spaces called as snowstorm appearance. And absence of fetal parts. There will be absence of fetal parts, absence of amniotic fluid, presence of theca lutein cysts. So snowstorm appearance with cystic anechoic spaces, snowstorm appearance, absence of fetal parts, absence of amniotic fluid and presence of theca lutein cysts. Whereas a partial mode will have cystic spaces in the placenta, decreased amniotic fluid, increased transverse diameter of the gestational sac, which resembles missed abortion. It resembles missed abortion. Accurate diagnosis is made after histopathological examination. Increased transverse diameter. There will be increased transverse diameter of the gestational sac. Management for complete mole and partial mole is suction evacuation for any gestational age and size of the uterus. Suction evacuation for any age and size. Suction evacuation for any age and size of the uterus. Keep packed cells ready as chances of bleeding is more. Keep packed cells ready as chances of bleeding is more. After process begins, you have to start oxytocin. If oxytocin is given before suction evacuation, it can lead to trophoblastic embolization. Do sharp curettage. After procedure, set the tissue for histopathological examination. Histopathological examination is the gold standard for diagnosis. If the age of the patient is more than 40 years plus family is complete and it is a complete mole, you have to do hysterectomy. Suction evacuation for any gestational age or size would be confusion create करते हैं. Suction evacuation packed cells after the process begins start oxytocin. If it is given before suction evacuation, it can lead to trophoblastic embolization. Do sharp curettage after the procedure, send the tissue for histopathological examination. Do sharp curettage and after procedure. Do sharp curettage after procedure, send the tissue for histopath. If the age of the patient is more than 40, family is complete and it is a complete no, you have to do hysterectomy. Management of theca luteins is no management resolves spontaneously after evacuation while doing hysterectomy. Theca luteins do not need removal. On histopathological examination, in a complete mole, fetal or embryonic tissue will be absent. Hydropic swelling of chorionic villi will be diffuse. Diffuse hydropic swelling of chorionic villi. So a complete mole will have absent fetal or embryonic tissue with diffuse hydropic swelling of chorionic villi and diffuse trophoblastic proliferation. Scalloping of villi will be absent. Trophoblastic inclusion bodies are absent. Trophoblastic inclusion bodies are also absent. Now suppose you have fetal embryonic tissue which is present, okay, in an incomplete mole or partial mole mein fetal or embryonic tissue will be present and hydropic swelling of chorionic villi will be focal. Trophoblastic proliferation will also be focal. Trophoblastic proliferation is focal. Scalloping of villi will be present. Scalloping of villi and trophoblastic inclusion bodies are seen in partial mole, okay. Partial mole will have scalloping. Partial mole will have scalloping of villi and inclusion bodies, trophoblastic inclusion bodies. Scalloping of villi and trophoblastic inclusion bodies are seen in scalloping of villi and trophoblastic inclusion bodies are present, okay. Scalloping of villi and trophoblastic inclusion bodies are present in partial mole. Investigation of choice for molar pregnancies would be beta HCG. It is done using beta HCG levels. First level is after 48 hours. You have to repeat weekly till they become. So first done using beta HCG. First level is after 48 hours. Repeat weekly till they become undetectable. That is at 7 weeks, and then repeat monthly till 6 months. So till 6 months for a complete mole, we need to follow up till 6 months. For a partial mole, we need to follow up till 6 weeks. So complete mole is 6 months. How? First till 48 hours we have to check once, and then repeat weekly. Then repeat till they become undetectable. First at around 7 weeks they'll become undetectable. So test weekly till 7 weeks, and then repeat monthly up to 6 months. Pregnancy is contraindicated for 6 months in both cases, although not recommended, but a female conceives within 6 months. Rate of live birth and congenital anomalies mirror general population. Contraceptive of choice is OCPs, okay. Not recommended for 6 months. We have to do follow up for 6 months in complete and 6 weeks in partial. 48 hours, 7 weeks till they become undetectable, and monthly till you have to repeat it monthly. Now rate of subsequent gestational trophoblastic neoplasia. Rate of subsequent gestational trophoblastic neoplasia is 15 to 20%. In complete mode, 15 to 20% will have subsequent Gestational trophoblastic neoplasia. 15% is locally invasive, 4 to 5% will be metastatic. Metastasis is most common when gestational trophoblastic neoplasia develops after non-molar pregnancy. Most common site would be the lungs, vagina, pelvis, liver and brain. Rate of gestational trophoblastic, rate of subsequent GTN is 15 to 20%. 15% will be locally invasive, 4 to 5% will be metastatic. Metastasis is most common when gestational trophoblastic neoplasia develops after non-molar pregnancy. To 20, 1 to 5%. 15% will be locally invasive, 4 to 5% will be metastasis. 15% is locally invasive, 4 to 5% will be metastatic. Metastasis is most common when gestational trophoblastic neoplasia develops after non-molar pregnancy. Non-molar pregnancy. Most common site of metastasis would be lungs followed by vagina, lungs, vagina, pelvis, liver and brain. Role of anti-D infection in Rh negative after molar evacuation. Partial mole, fetal red cells with E antigen. Anti-D is given in case of Rh negative female. Complete mole also it is given because a definite diagnosis of complete mole versus partial mole may not be confirmed until histopathological examination of evacuated products. Risk factors for development is HCG raised, HCG more than 10 raised to 5 HOTS, which means HCG more than 10 raised to 5 milli international units per ml. HCG more than 10 raised to 5 milli international units. Older age group. So HCG more than 10 raised to 5, older age group, theca lutein cyst of more than 6 centimeters and increased size of the uterus more than gestational age. Increased size of the uterus more than gestational age, theca lutein cyst more than 6 centimeters, older age group and HCG which is raised more than 10 raised to 5. Now prophylactic chemotherapy is not given these days. Quiescent gestational trophoblastic disease. In some women, low levels of HCG, which is less than 200 milli international units, may persist for several months after evacuation, which indicates a small active focus. Low levels of HCG less than 200 international, 200 MIU per ml. Low levels of HCG less than 200 milli international units per ml may persist for several months after evacuation. Which means it will indicate whether a small focus indicates a small active focus. It indicates a small active focus. It should be followed up. It indicates a small active focus. In 20%, eventually it will lead to active disease. It doesn't need chemotherapy. A variant of beta HCG is hyperglycosylated HCG, may be used to differentiate between quiescent and active GTN. If present, it indicates GTN. Also, it should be followed up because this persistent level in 20% it will lead to active disease. It doesn't need chemotherapy. A variant of beta HCG called hyperglycosylated HCG or HCG-H, hyperglycosylated HCG, may be used to differentiate between quiescent and active GTN. If this hyperglycosylated HCG is present, it indicates active GTN. Then you have gestational trophoblastic neoplasia. Gestational trophoblastic neoplasia. Most common gestational trophoblastic neoplasia after molar evacuation is invasive mode. Choriocarcinoma most commonly develops after molar pregnancy. Most common GTN after molar evacuation is invasive mode. After molar evacuation is invasive mode, and choriocarcinoma most commonly develops after molar pregnancy. Most common GTN after non-molar or full-term pregnancy is choriocarcinoma. Choriocarcinoma most commonly develops after molar. Choriocarcinoma after molar evacuation, most common is invasive mole. Choriocarcinoma most commonly develops after molar pregnancy, and most common gestational trophoblastic neoplasia after non-molar pregnancy or full-term pregnancy is choriocarcinoma. Most common gestational